When I was in my 20s, I remember feeling really resentful of people who said to me that my biological clock was ticking. It just felt like a very Karen kind of thing to say to a younger woman.
It's not a matter of like the clock is ticking. Just understand how fertility works. Understand what your body is telling you. If there's something that's not right, whether it's irregular periods or you're having severe pelvic pain, take that time out to get it worked up. So there's also women out there that don't have those physical presenting symptoms that make it more obvious that they might have PCOS, but might be walking around with it. So that's why I think it's so important to do your workup, because if you have that diagnosis, for instance, with the PCOS, you have an elevated risk for diabetes, cardiovascular disease, and metabolic syndrome. And it's not that you have PCOS one day and it goes away. It's a lifelong diagnosis. So it's important for you to know that earlier on so you can optimize your health early on.
This is Second Opinions. I'm Christina Farr.
I'm Ash the News. And I'm Luba Greenwood.
Welcome to the pod, where each week we navigate what's really going on in healthcare through strikingly candid conversations with the entrepreneurs and investors leading the charge.
Thanks for joining us. Let's dive in.
Hi, everybody. Welcome to a new edition of Second Opinion, the podcast. We're so excited that you're here, and thanks for listening, guys. So this week I have on a friend of mine that I think you'll really enjoy hearing from. She's Asima Ahmad. She is the co-founder and chief medical officer for Carrot. So she's one of the most entrepreneurial physicians I know, and she also actively treats patients. She is a physician that specializes in fertility and infertility, and she sees patients at the Reproductive Medicine Institute in Chicago. Welcome, Asima. Thank you so much for joining.
Thank you so much for having me, Christy. I'm really excited to talk to you today a little bit about fertility.
Yeah, so before we get into fertility, which is definitely the hot topic, I just wanted to ask you a little bit about just what your experiences have been like in medicine, trying to be or being entrepreneurial, because you've had some success in your career with this front. But, people often say to me that physicians are not good at starting companies, that they don't have that kind of lean startup mindset. I think you're sort of living proof that that isn't true. So walk me through a little bit of just like that convergence between tech, medicine, startups, and how have you been able to kind of balance all those things at once?
So it's funny that you mentioned that, because I never, growing up or even during my training, thought that I was going to go this route. But what I did know was that I loved patient care, that interaction that I have with the patient, helping them reach their goals. But I also wanted to do something that could affect more lives. And actually, I did my master's in public health and focused on global health because I also wanted to do something on a global level. I just didn't quite know how I was going to do it. I did an internship at the World Health Organization. I thought maybe I'd go back and do work there, or maybe I'd work with a nonprofit, but I never, in that time period, thought that I would end up starting a company. And I think that's the case for a lot of physicians, at least the ones that were training at the time that I was. I think that the culture has been changing over time, is that we're not really taught about things when it comes to the business of medicine outside of the clinical setting. We focus a lot on training in the hospital and how we would practice if we practice out of a hospital or even a private clinic, but we don't really go into other careers outside of medicine. And again, I think the culture is starting to shift a little bit here, but I think that was something that was starting to come about at that time when I was going through my medical education and training. Because during medical school, I actually took off that year to do my MPH, and I was thinking about MPH versus MBA, and that wasn't something that people typically did. Typically, you went to undergrad, you went straight to medical school, you went to residency, plus or minus a fellowship, and you'd go straight to practicing medicine. And I think for me, I just happened to be at the right place at the right time when I met my co-founder, who I actually met at a fertility conference, the national one that we have every year, done by American Society for Reproductive Medicine. And I think the way that it turned out for me was that while I was in training, I was picking up a lot of like friction in the experience of the patient. You were lucky that we were in a clinic that was very busy, and we were lucky that we got to have a lot of interaction with our patient population. So I would see patients on multiple occasions, and you'd really get to know them, and you try to understand what their journey was like. And a recurring theme was that people were having trouble getting into clinic because of financial barriers. Either they had put off seeing a doctor because it was so expensive to even get in to do the consultation, or they had put off treatment, again, because of cost issues. So maybe they were taking out loans now. Maybe they moved back in with their parents. Maybe somebody else was giving them financial assistance. But there was this great financial burden, and that was one of the biggest barriers to access to even walk into the clinic. And even during their experience, I mean, taking those injections, I mean, most of these patients were super, super healthy, and they had never given themselves an injection. They didn't have any chronic medical issues that they were taking medications for. So it was pretty stressful for them to have to go through that experience. And then when they would get pregnant, the bleeding, and there were all these things that were coming up. So when I met my co-founder, she was a patient that had gone through the fertility treatment. So we talked a lot about what the barriers were, what the friction was, and how we could make things better. And I think the other thing that really lined up for me really well was that I honestly, I feel like I had the world's best fellowship director when it came to reproductive endocrinology and fertility. I love Dr. Marcel Cedars because I felt that I could go up to her and ask her anything and she would happily give me a response. And it was a very honest response. And I really, really appreciated that because I learned so much from her. And when I talked to her about this opportunity to try to solve these barriers to access and try to improve the patient experience, and I said that I have this opportunity to start a company, and we applied to Y Incubator and we got in, like, is it something that you would support me doing? And she's like, absolutely. Like, you have your responsibilities on the clinical side as a fellow and your research. And as long as you're doing all that work, I fully support you going out and trying to find ways to increase access to care. And actually, that was one of the reasons why I really wanted to go to this program, is because they really, really tried hard to teach us ways to increase access. And even in some cases, like being able to provide treatments that were more cost effective, but would still yield high quality results for the patient. So I think in my case, it wasn't something that was planned, and everything just happened to line up in a way where at that moment in time, it made sense. And I'm so proud of what we've been able to build over time. And to the last part of how do you do it? I mean, how do any of us do it? We just do. And I think the biggest thing for me is having a great support system. I have my parents, I have my family, I have this amazing nanny, or Joanne. She's been so helpful in helping us raise our kids here in Chicago. And I also have another addition to our support system, Cindy, who's been helping us eat healthier, which honestly is something that I've been trying to focus more on given that I have PCOS.
Okay, so a lot to just unpack in all of that. Maybe we'll just take a step back and talk a little bit about this role that you have as a reproductive endocrinologist. It's a bit of a mouthful, so sometimes I just say fertility doctor. So forgive me for that. But you are in a very coveted, very scarce position because there are just not very many people like you in this country, which is just shocking given how many people have fertility issues. I mean, in my friend network, it seems that it's more than 1 in 6 that are having issues, whether it be PCOS, whether it be endometriosis or something on the male side, which again is extremely common these days and something we've talked a lot about on the pod. So tell me how we got to this point where we just have so few people like you to treat just this like growing demand amongst patients who need help to have kind of the family that they had intended.
Yeah. So the thing is, there's only about 40, at least when I graduated, there was about 40 fellows graduating a year from the Reproductive Endocrinology and Fertility Fellowship. I believe that number has now increased to somewhere in the lower 50s, which obviously is an improvement. But as you mentioned, the demand is much higher than the current supply. It is a very competitive training program to get into. And I do believe that a lot of programs are taking initiatives to slowly increase the number of trainees that are coming through over time. But you and I and the rest of us hope that it continues on that trend and we're able to have more reproductive endocrinology and fertility specialists. And I agree, it is a mouthful. It's a very long title. So sometimes we just shorten it to REI, which is what I'll probably be used then moving forward during our conversation today.
Yeah, I was going to say, I mean, it's true, very few REIs, and I like the shortening. There are a lot more OB-GYNs though. And they are a special kind of specialist in that they can do surgery and really complex things, in addition to everything that they do on the OB side with maternity, and on the GYN side, which is much more really everything that a woman goes through in life where they need specialized help. So why not have more of those physicians really helping with fertility treatment? Do you think that that is something that we can count on in the future?
I think that's a really great point, because one thing that we've seen, and I've learned personally through my experience through Carrot, is that when we started off the company, we started off as global. And so I get insight, and our team has insight into what's going on in so many different countries across the world. Like right now we're within 170 plus countries. And what you mentioned is what happens in some other countries, in that the OB-GYNs are the ones that are doing the initial fertility workup. They're the ones that are doing the ovulation induction, the intrauterine inseminations. And it's when the person gets to the point of needing IVF, then they're referred to the fertility doctor to have that completed. So do I see that in the future the model may change over time? It's possible. And honestly, if you look in the United States, there are some places where they're already practicing in this way. Like if you go to some areas where a fertility clinic might not be located nearby, or it's more rural care, the OB-GYN does take a lot of that on themselves in terms of doing that workup for the female patient and ordering that semen analysis for the male patient, and then starting them on ovulation induction, if that makes sense, and or IUIs, and then referring to a fertility doctor when they need it, because they're trying to do as much care as they can locally and making it more accessible for that patient, that person. And when they need to have higher level of care, then they're transferred over to the REI. And the nice thing, I hate to bring it up, around the pandemic, but one positive that came out of the pandemic is that virtual care is much, much more accessible for people as opposed to where it was before. I know for many of my patients, they were unable to do a virtual consultation unless they lived more than 3 hours away. And 3 hours is, yeah, like it's not 10 hours, but it's still 3 hours. So like you expect someone to drive 2.5 to 3 hours both ways to see me, probably having to take the whole day off from work. And especially if they're coming with their partner, it's going to be two people having to take the whole day off. And the nice thing about virtual care is you can do it from the comfort of your home. I have people who call in from their office. I have people who call in from their car. One partner might be one location, the other one's in another. And so it really helps with getting people in a timely fashion, not pulling them away and having them have to take off a whole day off from work. So it actually provides better, faster care. And so that's what we're starting to see more of too, is that doing that initial workup, initial treatment with the OB-GYN, and referral to a fertility clinic. And the nice thing about that also is because that OB-GYN is able to do some of that fertility work, they might also be able to do what we call monitoring, meaning like local ultrasounds and blood tests during the treatment. And the patient may just have to drive over to the fertility clinic for the actual procedure.
That makes so much sense to me.
Hey everyone, we'll get right back to the conversation after a word from our sponsors. Today, I'm excited to share a true scientific breakthrough for your long-term health. C15, the first essential fatty acid discovered in 90 years, and it's 3 times better, broader, and safer than omega-3. Dr. Stephanie Van Watson discovered C15 while working with the US Navy to improve the health of aging dolphins. Here's why this matters. Many of us are deficient in C15, resulting in weaker cells that make less energy and quit working earlier than they should. This makes us age faster, sleep poorly, and feel sluggish. C15 is a science-backed, vegan-friendly supplement with pure C15 as its only ingredient. It strengthens your cells, improves mitochondrial function, and protects against damaging free radicals, supporting better metabolic, heart, and liver health, plus deeper sleep and healthier hair, skin, and nails. Unlike fish oil supplements that often go bad, Fatty 15 naturally protects against oxidation. It even comes in a beautiful reusable glass and bamboo jar with eco-friendly refills. Ready to restore your long-term health? Get 15% off your 90-day subscription starter kit at fatty15.com/second-opinion using code second-opinion at checkout. This show is sponsored by Midi Health. There are certain things that come with age: wisdom, experience, and knowledge, to name just a few. But if you're a woman over 40, it can also bring some less desirable things: hot flashes, insomnia, brain fog, moodiness, and weight gain, all symptoms of menopause and perimenopause. Yes, hormonal transition is a fact of life, but that doesn't mean you should have to accept its symptoms as just another part of aging. The experts at Midi Health understand what you're going through and know how to help. Midi Health is the only virtual care clinic for women navigating midlife hormonal transition. They support you with safe, effective, FDA-approved medications, as well as supplements, lifestyle coaching, and preventative health guidance. What's more, all their services are covered by insurance, and they're conveniently accessible through telehealth visits and 24/7 messaging. If you're over 40, use all that wisdom you've gained over the years and visit Midi Health. You deserve to feel great. Book your virtual visit today at joinmidi.com. That's joinmidi.com.
I heard this kind of funny and also kind of harrowing thing recently. I don't know how I feel about it, but it was somebody told me at a dinner that there was a whole trend called revenge egg freezing. And that's with all these tech companies that did a bunch of kind of layoffs in the past couple of years, have really good benefits around fertility, in some cases offer completely free egg freezing. So people were kind of rushing to get their eggs frozen right after getting the word that they had been let go from their organization, either through COBRA or just like they had a few weeks left. And so they went and did it. And part of me was like, okay, like I support that, like get your healthcare while you can. And then the other part of me was thinking, is there a trend that we should be concerned about where people that have no real kind of fertility issues at all in their mid-20s are just going and getting this done? And does that mean that somebody who does have that kind of serious health reason maybe can't see you because there's just too long of a wait list? How do you think about that?
First of all, I didn't even know about revenge egg freezing, so I find that terminology fascinating. But I agree in that when people have coverage, I understand why you'd want to be able to access that care in that time frame. Because when you are, for example, thinking about egg freezing, it can be upwards of like $10,000 plus, depending on like what dose medications you're on and what facility you're having your procedure done at. So it can be a significant amount of money for some people who might not have the savings to be able to do that. And at the end of the day, I don't think the financial burden of being able to take care of your health should fall on a person. Like, I believe that healthcare is a human right and everyone should have access to it regardless of their financial background. Do I think that there might be an overuse? I think that sometimes people may do it because they know they have the option, even though it's not something that they might have done otherwise. I don't know if I would call it overuse, but I think I understand what you're trying to get to there. Would that make it harder for people who really, really need to get the care to get in? Now, there are some clinics that have really long wait times of like 3, 4, 5, 6 months, but most clinics are able to get people in within a few weeks and in sometimes the next day. So most people don't have to wait. And especially if they have a medical diagnosis, a lot of clinics will make an exception. They'll extend their schedule for the day. They'll do whatever they have to do to get that person in. I have patients that see me because they have newly diagnosed cancer and they want to do egg freezing or even embryo freezing before they start their chemotherapy or radiation. And I mean, I'll extend my schedule and get them in as soon as possible. So usually if it's like a real serious medical condition, like most clinics will do whatever they can to get the person in. We want to make sure that they have the time and the ability to do it before they have to do such an important treatment for their medical diagnosis. But I do understand that could be a fear, and that because there's already a low supply of providers and having more and more people using it, maybe for quote elective reasons, like would it make it harder for people who have a diagnostic, like an actual diagnosis of infertility or something like that to get in? I mean, it's always possible. Right now, I haven't seen it as much of a challenge because there are still clinics out there that can get people in quickly.
Yeah, I mean, I guess that again, it sort of leads me to another big question. There's so many ethical quandaries with this area. But okay, so I have a daughter. You have 2 daughters.
Yeah.
So if they said, "Mom, like I'm 21, I have a lot of good, high quality eggs at this point in my life. Should I just do this, like as a preventative thing?" Would you say, sure, like good idea? Or would any part of you say, well, we don't know what maybe the long-term risks are associated with all the hormones you have to take and all the rest of it? Because it is a very invasive procedure and it can be really tough on your body.
Well, if one of my kids asked me, I would fully support them to be able to, like just in general, if they wanted to do a treatment that's going to help prevent something in the future or help them prepare for building their family, and it might be challenging later, I would fully support them in doing the treatment, obviously, as long as I know that it's safe. Egg freezing is a very safe treatment, but like I think before undergoing any sort of treatment, it's always good to review your full medical history, your family history, get all the important testing done beforehand so that if there is something that increases your risk of complication, that you know that beforehand. Or let's say your body for some reason may be sensitive to certain hormones because you've had a tumor that was stimulated by a hormone, like to try to keep that suppressed during your stimulation and customizing or personalizing that protocol for your body. I think though, learning about your fertility and understanding your body is always a good idea at any point in time in your life, because at least you're learning about where you're at now, what your options are in the future, and you can plan ahead. And whether that means you decide to do something like fertility preservation or you choose not to, I think that's a personal decision. But I don't think there's ever a bad time to learn about your fertility. I actually say that when they're teaching people about contraception and how to prevent pregnancy in junior high and high school, that they also go over, well, there are some people, actually 1 in 6, that might have difficulty getting pregnant. And as you age, these are the symptoms that you're going to feel when you're going through perimenopause or menopause. And it doesn't have to be like a 2-day course, but at least touching on those topics that they don't even go over right now. I think that's really important so people can learn about their bodies and plan ahead.
Yeah, that's a really good point, and just good to hear it's safe and kind of generally well observed, because there's so much just bad information out there on the internet that sometimes you just don't know how to feel as a patient. And I wonder if that is something that just becomes way more common in the future. Like, there are so many ways in which we sort of save for the future and think about the future. And with how common it's become to have some kind of infertility issue, like, how do you think that all these things get redesigned or thought about in, say, 20 years from now? Is it just something that becomes really affordable and everybody just does because it's a couple $1,000s and why not? And then does this become the predominant way that babies are born? Is IVF kind of replace kind of more traditional methods of making babies? And there is a great book written about this, by the way, called The End of Sex by Hank Greeley that I recommend to anyone on the topic. But that's essentially the hypothesis of his book.
Yeah, and I think you're bringing up a great question, because that has come up with different groups of people. Like, is this going to change the way that we plan to grow our families? Do we just start telling our children to do fertility preservation early on in life? I don't think today I could say that that's the case. I think the thing is we still need to, one, obviously, like there's the affordability component, but also learn a little bit more about how our bodies are changing over time and whatever exposures that we have had, whether it be for us or the generations before us, are affecting our fertility. I think there's a lot more that we're learning there. There's actually also research being done to see if there are ways to delay ovarian aging, where maybe we don't go through menopause, where right now the average age is 51, but maybe it happens later on in life. So and I just love that you brought it up, because even within my circle of friends, like, this is something that we talk about. It's possible, but I think that, like, if I had to answer that question today, I can't say that with certainty. I think right now the most important thing is for someone who is thinking about building a family in the future, initiating fertility testing, just to know where they're at right now, because if there are some abnormalities, they can try to work to improve those so that by the time they're ready to start growing their family, they have better sperm, or maybe they have improved their overall health. Maybe with weight loss now they're ovulating. So there's definitely things that they can do proactively. And again, if it makes sense, then they can do things such as fertility preservation.
Yeah. And I just, on a personal note, have lived that myself as somebody who had no idea they had PCOS, and then a fertility, an REI actually diagnosed me with it. So there was no way that I probably would have found out about this otherwise. So I do agree with you. And I think that's a great thesis of just like, let's give women the tools to be able to discern if they are likely to have infertility issues for any reason, or if maybe they might have late menopause. And so that was another thing I learned through kind of going to a clinic, is that I'm somebody who maybe will have late menopause. It's also something my mom had very late menopause as well. And so that I was told it was sort of often kind of you talk to your mom and that's an indication of what might happen to you. But in general, like most women I know have absolutely no idea about any of these things, and it makes family planning really challenging.
Chrissy, I'm so glad that you brought up the delay to diagnosis for your PCOS, because that's happened to me as well. The thing is, when people start having their periods, it's not uncommon for them to be irregular in the very beginning, where they might sometimes skip a month or two. And the reason why I think a lot of people have a delay is that sometimes they'll be placed on medications like birth control pills to make those cycles more regular. And they don't realize that if they were off the pills, they would have continued to be irregular. The other thing is that PCOS doesn't present the same way in different people. Most REIs use the Rotterdam criteria for diagnosis. And what it means is you need to have 2 out of 3 things. And the 3 categories are irregular cycles, not explained by other things. So someone who doesn't have periods at all, or is maybe skipping cycles, or the periods are really far apart. The second thing is what's called polycystic appearing ovaries or polycystic morphology ovaries, which is confusing because it has nothing to do with cysts. It has to do with how many follicles you have in your ovaries or the volume of your ovaries. And follicles are those little fluid-filled sacs that surround eggs that are trying to grow for that month. And then the last category, we call it clinical or biochemical hyperandrogenism, meaning that either they have signs of elevated androgens, like an androgen, an example is testosterone. So someone might have acne, they might have excessive hair growth, they might have male pattern hair loss, or that when they get their blood tested, they have elevations in those hormones. So you just need to have 2 out of those 3 things. And I think in your case, Chrissy, and obviously let me know if I'm incorrect, you didn't have obvious signs of it. You didn't present with severe acne. You had regular periods, but when you did your testing, it probably revealed that you had these polycystic morphology ovaries, and maybe you had an elevation in one of your hormones. So there's also women out there that don't have those physical presenting symptoms that make it more obvious that they might have PCOS, but might be walking around with it. So that's why I think it's so important to do your workup, because if you have that diagnosis, for instance, with the PCOS, you have an elevated risk for diabetes, cardiovascular disease, and metabolic syndrome. And it's not that you have PCOS one day and it goes away. It's a lifelong diagnosis. So it's important for you to know that earlier on so you can optimize your health early on and not wait till you develop something like prediabetes or diabetes.
Yeah. For me, it was just the irregular periods, and then also just not very high quality eggs when I did my egg freezing, which is another kind of indication. And there are a few other signs that also runs in the family, but it was something I probably never would have really discovered because I had just a lot of misconceptions about PCOS in general, which I think is just really speaks to the lack of education that women have around their fertility, their bodies in general. I'm going to share a hot take. And I feel like I'm going to get some emails about this that maybe are a little bit negative, but I'm going to do it anyway. So when I was in my 20s, I remember feeling really resentful of kind of people who said to me that my biological clock was ticking. And I was like, I'm having fun, I'm enjoying my career. And like, it just felt like a very Karen kind of thing to say to a younger woman. And then I hit my kind of 30s and early 30s and did get married and started to think about having kids. And I didn't have like excessive or really complex fertility issues. But as I kind of got deeper into having my own kids, I just saw my entire friend network, it seemed like, had fertility issues. And B, like I saw for the first time my own age kind of sort of really staring back at me, because you do experience ovarian aging. You do experience a drop in egg quality as you get older. And these things are real. They may be less real for some women than others. And maybe the rate of aging is slower in some women than others. I mean, you're an expert on that, Asima. But it brings me to this sort of spicy question, which is, for women in their 20s, do we need to have that conversation with them that like, maybe you don't have all the time in the world? And I know that it's like, we have to talk with men too, because men are a big part of the problem. They're like on these dating apps and being non-committal in many cases. And it's definitely not on women, but it's just not a dialogue that we even have. Like, we tell women you can have it all. You can have the career, you can have the kids, you can have the family, you can have everything. And then for a lot of my friends, it was like this rude awakening that there's just competing priorities all over the place. And there isn't really a forum to even talk about this stuff with anybody, because these are such hot button issues. So where do you land on that, just in terms of just patient education or your own experiences with your friends and the things that you know and have seen in your own life, both personally and professionally?
Well, I agree in that you can have it all. I think what it comes down to is education. And just like you mentioned, education for both men and women, and honestly, girls and boys. I think you should start talking to people about their fertility early on, before they're even thinking about having children, and educate them that, you know what, this is a thing. Age is going to play, especially for the female, a very large role in her fertility potential as she gets older, because that egg quantity is going to decline, because the quality of those eggs are going to decline. So at least that seed has been planted. And then over time, just going over that, right? Like, if the first time you talk about fertility and how age impacts it is in junior high, even if it's a couple of sentences, plant that seed, bring it up again during high school. And so when they start having their periods, you start seeing their gynecologist, that's something that they're going to be aware of. It's not a matter of like, the clock is ticking. It's like, just understand how fertility works, understand what your body is telling you. If there's something that's not right, whether it's irregular periods or you're having severe pelvic pain, like, recognize that, take that time out to get it worked up. Because I think a lot of people, whether it comes to fertility or your menstrual cycles or pelvic pain or all these things, a lot of times they're just like, you know what, it happens to a lot of people, so just move on, take this pill and move on. And I think people just need to be educated better about all that. And that's how people can, like I said, they can plan in advance, or they can be diagnosed earlier and be treated in a timely fashion and not have to suffer through something like endometriosis pain.
Yeah, I do think you're right that we just need to talk about it a little bit more. And if you do have fertility issues, like, you should have that information as young as possible so that you can plan your life around that. I think my good friend Leslie Schrock has this saying that, like, women can have it all, just not at the same time. And so I think there are moments of our lives where we just want to crush the career and not think about anything else. And then there are other periods that maybe it's worth just doing some testing, doing some education, like figuring out what your level of risk is, and then have that conversation with yourself around whether or not you want to have a family. And then what is the timeline that, you'd love to see kind of around that. And of course, dating is hard. I mean, I I feel like it's just, if anything, gotten more and more challenging. But these are all things that I just feel like we just don't talk about and should.
Yeah. And I think the sooner the better. I think that's the thing, is sometimes we do wait till somebody comes into the clinic and they're 35, and then the doctor mentions, hey, like, what are your thoughts on family building and what are your plans there? I mean, those conversations should be happening well before, and not just be in the clinical setting. Like, you can do that in schools. You can do that with your children. I just think that there was, for so many years, that taboo, the stigma around the discussion of infertility. And so it's like, it's just not something that was discussed. And I think the same thing and especially in some cultures with menopause even, but I think that has been shifting over time. And so we just need to be more open about talking openly when it comes to our reproductive health.
Okay, so last question for you, and I just appreciate this dialogue, but I'd love to hear about any kind of innovation that you've seen in this area, like any cool technology, anything that you think could really move the needle when it comes to fertility treatment, ideally in the right direction, making it more affordable and accessible.
So one of the things that I've been excited about, this stuff has been looked into for several years, but at some point I'm hoping it's going to be considered the standard of care in the clinical setting, is in vitro maturation. So right now, women who are doing IVF or egg freezing, they'll take multiple injections a day over the course of 8 to 14 days on average to grow those follicles and help their eggs start developing and getting to that point where they're mature enough so that when they're retrieved, they can be fertilized in, the laboratory, the embryology lab setting. And right now, like what's considered a fully mature egg in the embryology lab, for example, is an M2 that can be fertilized. In some labs, the stage right before that, that's called M1. Some of them can mature that in vitro to an M2 stage and fertilize it. But then there's other eggs that are still very like much less mature, which are called germinal vesicles. And so what happens with IVM is that patients can have their eggs retrieved sooner without having to take as much medications, and even at those earlier stages of something like a germinal vesicle. So it takes a lot of that burden off the person of having to go through that whole process and allows a lot of that maturation of the egg to take place in the embryology lab. So I find that really exciting because not only does it take like that physical burden off and like logistical burden, but also like the financial piece, because like the medications, for example, themselves are pretty expensive. So that's one thing that I'm really excited about. The other thing is there's a research being done, and I kind of alluded to this earlier, on seeing if there's a way to delay ovarian aging. So there's a study that's being done in New York that's looking at rifampin, which is, or let me just make sure I said the medication name correctly, but there's a study being done in New York that's looking at a medication that can be given that's used for other purposes typically, but to see if that can help to delay ovarian aging, which means that menopause will happen later and you might be fertile for longer. So those are a couple of the things I'm really excited about.
Ooh, that sounds fascinating. And you'll have to keep me posted on both. Maybe we'll do another episode in 6 months and we can just talk about this because there's so much more to share and to discuss. But it was phenomenal to have you on, Asima. I love this topic and I'm somebody who just loves following you on Instagram. I'm just going to say that because you have such great content that you put out, both kind of in scrubs and wearing your kind of more entrepreneurial hat. So if you are someone that is struggling with fertility, like you should definitely follow Asima. Can you share your handle?
Oh, yeah, it's Dr., like the full word Dr._Asima.
Amazing. Okay, great. Well, follow Asima and thanks for tuning in.
Thank you.
Thanks for tuning in to Second Opinion. Share it with colleagues and friends and message us to let us know what topics you want to discuss on the podcast. If you want to support the show, the best ways are to leave a review wherever you're listening and make sure you are subscribed. And check out Christina's Second Opinion newsletter on Beehive. A link to subscribe is in the episode description. Second Opinion is part of Turpentine, the podcast network behind Turpentine DC, Age of Miracles, and more shows for experts by experts in tech.
Hey everyone, Eric here. At Turpentine, we're building the first media outlet for tech people by tech people. We're the network behind the show you're listening to right now. We have a slate of hit shows across a range of topics and industries, from our AI and investing cluster of podcasts to shows that drive the conversation in tech with the most interesting thinkers, founders, investors, and influencers, like Econ 102 with Noah Smith. We're launching new shows every week, and we're looking for industry-leading sponsors. If you think that might be you and your company, email me at ericaturpentine.co. That's ERIK at turpentine.co, and let's partner together.